Rheumatoid arthritis is something that you'll see pretty frequently. It affects 1 in every 100 people in the United States, and it is one of the most common autoimmune diseases that you'll see on wards and on USMLE. So let's talk about it. So rheumatoid arthritis is a chronic inflammatory systemic disease that's highlighted by severe joint pain. So what does that mean? Chronic, meaning that it goes over a long period of time and accompanies the patient over their entire lives. Inflammatory, meaning that there is real joint inflammation going on here. There's external joint inflammation. You're going to see this. It's warm, it's erythemic, it's enlarged. These joints look inflamed. It's systemic, meaning that there are other manifestations of rheumatoid arthritis other than just joint pain. But the disease itself is highlighted by its joint pain. That's why it's called rheumatoid arthritis. Rheumatoid arthritis is a progressive disease. It gets worse over time, and our goal as physicians is to slow this progression because this progression will drastically reduce the quality of life. As mentioned, it affects approximately 1% of the population, but it doesn't affect all people equally. So women are affected more than men by a 3-to-1 ratio, and its incidence is approximately 5 times higher in Native Americans, and it affects whites more than Asians and blacks. Pathophysiology is not yet completely understood, but we do know that it's T-cell mediated, and the reason we know this is in part because patients with rheumatoid arthritis that develop HIV/AIDS actually see an amelioration in their symptoms because of the depletion of T-cells. The diagnosis is based on clinical imaging and laboratory criteria. And so criteria is important here because it means that that's going to dictate how you diagnose this. It's not based on one or another factor more than another. There's no pathognomonic test. You have to fit 4 out of 7 criteria. Once you fit those criteria, then you are diagnosed with rheumatoid arthritis. There are serological antibodies that you can detect in the patient's bloodstream, and those would be rheumatoid factor and anti-CCP. Don't ask me what CCP stands for. It's like citrullinated something protein. But regardless, rheumatoid factor and anti-CCP antibodies, when they're positive, that's highly suggestive of rheumatoid arthritis. But a patient can be negative for both of those and still have rheumatoid arthritis. So let's slice up rheumatoid arthritis. First, systemic. Yes, as we mentioned, it is a systemic disease. Most patients will have a history of fatigue, malaise, nausea, weakness prior to the onset of joint pain. Approximately 8 out of 10 patients will have a demonstrable history of fatigue, malaise, and weakness prior to the onset of joint pain. So it's important when a patient comes in with joint pain that you're getting a retrospective history. There are multiple systemic complications of rheumatoid arthritis. First and foremost is anemia, and that's the anemia of chronic disease, and that accompanies any chronic inflammatory disorder. Felty's syndrome is unique to rheumatoid arthritis. We'll talk about that later, but that's rheumatoid arthritis along with a drop in white count and splenomegaly. And then Baker's cysts are also notable in rheumatoid arthritis. The location. So rheumatoid arthritis primarily affects the hands, but it's unique from osteoarthritis in that it spares the distal interphalangeals. So it affects the metacarpal joints, it affects the proximal interphalangeals, it can even affect the wrists, but it does not ever affect the distal interphalangeal joints. So you should know that frontwards and backwards for the USMLE, because if the distal interphalangeal joints are affected, you should be thinking something other than rheumatoid arthritis. Rheumatoid arthritis can also affect the shoulders, knees, and hips, but it tends not to affect the lower back. And when you look at the patient, when the patient tells you which joints are painful, it's usually a symmetrical distribution. The inflammation is prominent. The joints are warm, erythemic, and tender. The chronicity, of course, this is a chronic, insidious, and progressive disease. What's important to remember as far as the chronicity is that the pain is worse in the morning. So when the patient uses their joints as the day goes on, that actually makes the joints feel better. But when they've been immobile for a long period of time, then the pain gets worse. So patients will often complain of morning stiffness. And as far as trauma, there's no evidence of trauma with rheumatoid arthritis. It's not associated with trauma at all. So how do these patients present? Their presenting complaint will be joint pain. Not a surprise there. However, what makes this unique is that the pain is worse in the morning or after resting, and these patients will give you a history of fever, malaise, or pallor. Now, they might not give you that history. You might have to you might have to question the patient on that. But if you question the patient, they tend to have an unusual history of unexplained fevers, malaise, paleness, etc. The span of the symptoms, because remember, rheumatoid arthritis is a progressive disease. It depends on how progressed they are. So if they present with early rheumatoid arthritis, they're not going to present with the same spectrum of symptoms that if they had late rheumatoid arthritis. The average age of onset is 35 to 50 years. Coincidentally, we're seeing patients present with RA younger and younger, and part of that may just be because of the increased awareness of it. On physical exam, what you'll note is a warm, tender, erythemic joints. Particularly, these will be the hands and the wrists, and the DIPs will be notably excluded. And that's very important for making the diagnosis of rheumatoid arthritis. So unlike osteoarthritis, you have warm, erythemic, enlarged joints. Osteoarthritis, you don't get that. The joints are painful, but they're not outwardly inflamed. And unlike osteoarthritis, you've got distal interphalangeal joints that are excluded. You don't have distal interphalangeal joint pain in rheumatoid arthritis. Now, as I mentioned, the findings are going to depend on the progression. As rheumatoid arthritis progresses, you get ulnar deviation of the digits, so the digits will actually shift towards the ulnar side, so they'll shift medially. You can get what's called a boutonniere deformity, which I'll show you in a little bit. You can get nodules on bony prominences, on the knees, on the elbows, on the shoulders. Those are rheumatoid nodules. You can get them on the ribs too. And cysts in the popliteal space. So the popliteal space is the space behind your knee, and that is called a Baker's cyst. And all that is a cyst of joint fluid extending into the calf. So those are some of the other things you may see on physical exam in patients with rheumatoid arthritis. So these are the technical diagnostic criteria from the American College of Rheumatology. What I want you to do is I want you to remember what rheumatoid arthritis looks like. I don't want you to memorize this technical criteria. I want you to get into your head a general idea of what rheumatoid arthritis looks like. So rheumatoid arthritis has morning stiffness. That sets it apart from a lot of the other arthritides. And the morning stiffness will be present for more than an hour. So other arthritides may have some quote-unquote morning stiffness, but patients with osteoarthritis have morning stiffness for a prolonged period of time. But as the day goes on, the joints tend to feel a little bit better. Swelling of 3 or more joints for more than 6 weeks. You can see that this is a chronic disease, so the symptoms have to be going on for longer than 6 weeks in this case. Swelling of the joints, so remember we said that this is an inflammatory joint process, so you do have to have visible swelling. Swelling of hand joints for 6 weeks, symmetric joint swelling for more than 6 weeks, and then we go on to subcutaneous nodules. If those are present, that would be another check off here. And then a serologic test for rheumatoid factor, if that comes back positive, that's another point. And then deformities known on radiography. So the first 4 of these you could exclude or include clinically. And you could technically diagnose a patient with rheumatoid arthritis just with a clinical diagnosis. But most of the time, they're only going to have like 2 or 3 of these 4. So you're going to have to look, do they have subcutaneous nodules? And then at that point, you're going to, if you only have 3 of these or 2 of these, you're going to have to find if they have rheumatoid factor or if they have any deformities noted on radiography. Which of these is cheaper to run? It's going to be the X-ray. Rheumatoid factor is much more expensive to draw. So, usually, I would say actually always, the first best diagnostic step in diagnosing a patient who's suspected with rheumatoid arthritis is radiography of the affected joints. So these 2 are going to be what you'll want to know for the next step in diagnosis. These 5 are going to be the things that will be presented to you on a patient in a USMLE vignette. Okay, so as mentioned, that's the physical exam findings. Ulnar deviation, I'm going to show you a picture of that. So diagnosis, assuming the history is suggestive of RA, so assuming that they've got this morning stiffness, the swelling, the symmetricity, even subcutaneous nodules, at that point the next best step is going to be a radiography. And X-ray is perfectly fine. That tends to be what we do more often than CT. X-ray will generally be your test of choice, but know that CT is more accurate, as always. Rheumatoid factor should be drawn as well, but that is not your next best step, because if you get that 4th positive with your X-ray, then you save the money in getting the rheumatoid factor, which you'd probably get anyway, but X-ray is always the next best step in diagnosing rheumatoid arthritis. So do note that if a patient only has 1 inflamed joint, or if the inflamed joints are definitely asymmetric, so maybe my hand joints are inflamed on the left side and my right knee is inflamed, in that case, you're not suspecting rheumatoid arthritis because it's not a symmetrical joint problem. So in that case, you're going to get a synovial fluid test as your best first step. If the joints are symmetrically affected, then you're thinking more rheumatoid arthritis, so you're going to get an X-ray. But let's say a patient just comes in with knee inflammation, then a synovial fluid test may be the next step because you might be thinking possibly septic arthritis. If the synovial fluid analysis is ran on a patient with RA, so indeed on the USMLE you may get a patient with suspected RA, and you've got a synovial fluid reading, what you would get with rheumatoid arthritis is an elevation of white blood cells, but it'll be in the 5 to 50,000 range. So that's elevated, but it's not elevated enough to suspect septic arthritis. It gets much higher than that when it's actually a bacteria process going on rather than just a regular old inflammatory process. Okay, so how do we treat rheumatoid arthritis? So the treatment of rheumatoid arthritis is methotrexate plus or minus a biologic agent. We always use methotrexate in the treatment of rheumatoid arthritis. We used to use, and in some cases it is still used, hydroxychloroquine. Hydroxychloroquine, however, can cause retinopathy, so we tend to stay away from that. So methotrexate plus or minus a biologic agent is the mainstay of therapy for rheumatoid arthritis. So what are the biologic agents? These are primarily tumor necrosis factor alpha inhibitors, TNF alpha inhibitors. And what they do is they reduce inflammation, but remember the other things we use to reduce inflammation, steroids. Unlike the steroids, they don't cause the steroidogenic effects like weight gain and so forth. So the tumor necrosis factor alpha inhibitors include infliximab, etanercept, and adalimumab, which are marketed respectively as Remicade, Enbrel, and Humira. Now, anytime you start a patient on a biologic agent, you must, always, and this will come up on the USMLE, get a PPD test to rule out latent TB. So the same test you get every year because you're in the hospital, you're going to have to get on a patient with rheumatoid arthritis that you're going to start a biologic agent on. And that's any patient that you're going to start a biologic agent on. If they've got Crohn's disease, if they've got ulcerative colitis, so forth. So because these tumor necrosis factor alpha inhibitors, they cause immunosuppression, if a patient has latent TB, you want to know, because in that case, you're going to want to eradicate that TB before you put them on the biologic agent. If you put them on a biologic agent and they do have latent TB, they can actually go into active or fulminant TB, and that's a problem we would want to avoid. So get a PPD test to rule out latent TB. All they do is come back 2 days later, you read the induration, and you can exclude TB from that. As far as the methotrexate, the adverse effect from that is hepatic fibrosis. Unfortunately, these patients are going to have to come in approximately every 1 month to 2 months to have CMP drawn just to make sure that their liver panels are okay. Patients who are newly diagnosed with rheumatoid arthritis can be put on a short-term course of corticosteroids, and the reason for that is because it takes methotrexate and the biologic agents approximately 2 to 3 months to begin for the therapeutic effects to start. Patients usually won't notice them for the first couple months, and so to reduce the patient's symptoms, we can start the patient on a course of corticosteroids as sort of a bridge to their long-term therapy with methotrexate and a biologic. NSAIDs can also be used, and that includes the COX and COX-2 inhibitors. And they can be used for pain relief, and indeed they are used for pain relief, but they do not alter the disease course. Methotrexate and biologic agents reduce inflammation, and therefore they slow the disease course. Okay, so what are some findings associated with RA? First off is the ulnar deviation. This should be something that you always associate with RA because this is so dramatic. So here's the stages of RA, and you can see how it gets worse and worse in the same patient. Well, I'm not sure if this is the same patient, to be honest, but you can see, though, that it's obviously gets worse. You can also see on the proximal interphalangeal joints, you see your Bouchard's nodes here, but the distal interphalangeal joints are not affected. Here again you have more ulnar deviation, and you can see more Bouchard nodes. And here's another patient. Bouchard's nodes here and here. But again, not affected on the distal interphalangeal joints. So here's a Baker's cyst. So a Baker's cyst is sort of just a herniation of the fluid around the popliteal space. And a Baker's cyst is a common systemic symptom in rheumatoid arthritis. And how a Baker's cyst would present would be a mass behind the knee, a mass behind the calf, a painful mass behind the knee, or a painful mass behind the calf in a patient with RA. These also can happen in non-RA patients too. Okay, this is another thing that you see in RA, and it's due just to the breakdown of the bone and the joint space. Don't ask me much more beyond that, but know that they are associated with RA. So what you have is the boutonniere deformity, which is seen right here, and that's where you get this arching at the distal or proximal interphalangeal joint, and then the swan neck deformity, which is a similar arching at the distal interphalangeal joint. Okay, so what are some complications of rheumatoid arthritis? First off, you've got the adverse effects of the medications. So if you're on methotrexate, that could be hepatic fibrosis. If you're on the biologics, that could be infection. If you happen to be on a large amount of NSAIDs, that could be ulcers. There is, since this is a progressive disease, I suppose this wouldn't be a complication, but it is a reality of the disease. You have a reduction in your quality of life. Felty syndrome is one that USMLE likes to throw at you, and what that is neutropenia, so a drop in white count, and splenomegaly in a patient with rheumatoid arthritis. So sometimes this patient doesn't even realize they have RA, although I would imagine that in the real world that would be rare, as Felty syndrome is rare. I've never seen it personally. But a triad of RA, neutropenia, and splenomegaly is Felty syndrome. How do we diagnose it? Well, first we have to establish the patient has RA clinically. And then, of course, what's very important and which is generally very glaring is on CBC, they've got severe neutropenia. The proper therapy for Felty syndrome is going to be to treat their RA with methotrexate and the biologics. But we have to make sure that they do not have any kind of infection. Any patient with an infection that also has a concurrent diagnosis of Felty syndrome needs to be hospitalized inpatiently because they do need to get IV antibiotics and they need to be empiric. So we're going to cover gram-positives, gram-negatives, and gram-negative rods. So ampicillin and gentamicin, for instance, IV. So remember that Felty syndrome, the way we treat it is by treating the rheumatoid arthritis, but if the patient has any sign of infection, then you treat them inpatient with empiric IV antibiotics. Baker's cysts are a surgical disease, so we'll address that in a surgical section, but those are primarily just drained. They're cysts and they're drained. Carpal tunnel syndrome is seen commonly in rheumatoid arthritis just because of that it affects the wrists, and so you can get medial nerve entrapment. And the treatment for carpal tunnel syndrome is casting and immobilization. Atlantoaxial subluxation is something that's seen at higher incidence in rheumatoid arthritis, and that's because rheumatoid arthritis can affect the neck, which is generally the only part of the spinal column that rheumatoid arthritis affects. It doesn't affect the thorax and lumbar spine so much. It tends to affect the cervical spine if it affects the spine at all. So any patient with rheumatoid arthritis should be advised to caution anything that involves intense cervical motion. So like rides, for instance, at a carnival. They should also be advised not to see chiropractors. There are a lot of chiropractors that are unaware of atlantoaxial subluxation. And so I view chiropractors personally as witch doctors. I don't believe in them because of reasons like this, because they can cause things like this, and not out of their own anger, but this is a reason not to see a chiropractor. Patients with rheumatoid arthritis should be advised of the possibility of atlantoaxial subluxation. Now, a patient could present to you with atlantoaxial subluxation, and I should say atlantoaxial subluxation is a C1 and C2 spine. If a patient has subluxation in the atlantoaxial joint, what you would have is symptoms of impingement of the C1 and C2 nerves. And so what that would be is it would be hand and foot symptoms. So you would have paresthesias, anesthesias of the hand and foot, or even possibly quadriplegia. So the symptoms vary depending on how bad the atlantoaxial subluxation is. But if you have a patient with rheumatoid arthritis that comes in with upper and lower extremity paresthesias or hand and foot paresthesias, the next step is always a cervical spine plain radiograph, cervical spine x-ray, of course, after you stabilize the patient. You're going to want to make sure you put them in a C-spine collar and make sure that they're not moving. But get a plain radiograph of the neck if they present with symptoms consistent with atlantoaxial subluxation, in which your index of suspicion should be high in any patient presenting with hand and foot paresthesias that has rheumatoid arthritis.